It is with great pleasure that I introduce Dr. Jenny Higgins. Now, Jenny went to college at Colby College, so she's a maniac. She went from there to Emory to get her PhD in Gender and Women's Studies and her MPH in Global Health, because a lot of reproductive health is focused on other countries besides the US. She's done 2 postdocs, one at Columbia, one at Princeton. Arrived at the University of Wisconsin in 2012, where she joined the Gender and Women's Study Department. Yes. And I remember interviewing her before she came here and realized, oh my God, we need her in obstetrics and gynecology. So we're actually fighting over her chair in Gender and Women's Study and I, because the research that Jenny does is right up our alley. It's all about reproductive health and sexual health. She teaches a class of 500 students every year at UW. It's the largest women and gender study class in the United States. Her research is in behavioral research around sexual health and reproductive health. She's chair-elect of the Guttmacher. Did I say that right?
Yeah, Guttmacher.
So you guys know what the Guttmacher is, right? Yeah, it's like, that is huge. So anyway, welcome, Jenny. Let's give her a round of applause. Woo!
So hi, everybody. It's so nice to be here. I feel so pleased to be growing my relationships with the Department of OB-GYN. Ever since I got to UW-Madison about 5 years ago, I've been hanging out with a lot of you and sort of coming to meetings that you all let me come to, and now I feel like I'm a little bit more integrated. So I'm so happy to be here. I do a lot of research on sexuality and contraception and on sexual minority women and contraceptive use. Today, I'm going to be focusing on pregnancy ambivalence, which is another area of my research, mostly because some of the other studies I mentioned are so in the field right now that I look forward to telling you more about those in the years to come. So today, I want to talk a little bit about pregnancy ambivalence and how it matters to some of the work that you all do. So even though I am not a clinician, I'm a behavioral scientist, I started my interest in women's health in abortion clinics as a college student and a graduate student, counseling patients and doing medical assistance. And I got to hear amazing stories like you all hear every day. And folks, of course, at abortion clinics were there because they did not want to be pregnant anymore. But in talking to patients, I heard many more nuanced stories about how and why they became pregnant. And I think I had naively thought that people getting abortions are getting abortions because they didn't either know about contraceptives or they didn't have access to contraceptives. And that explains some, but many of the patients explain more complicated stories about, gosh, at the moment I got pregnant, I kind of wanted to be, and then later didn't, right? So that inspired, during my graduate career, some qualitative work, and I wanted to just share some stories that help contextualize the rest of my presentation. So Alexandra was a woman I interviewed. She's 27. She was a law student at the time, and she was talking about a relationship she'd had in her early 20s. And so she had gone off the pill because she didn't like the side effects, and so she was using a diaphragm. And sometimes they used a diaphragm and sometimes they didn't. And I was asking her about that. And she said, sometimes when I'm having sex with my partner, I would just kind of lose my mind a little bit and want to have a baby with him so badly. It was like I couldn't get close enough to him or connected enough with him, and conceiving a child would be the closest we could get. She, of course, went on to have a pregnancy because she wasn't using her diaphragm consistently, and even if she had been, there are failure rates, as you all know. So here's what she said about discovering she was pregnant. It seemed amazing that we could create this life together, and I suppose part of us did want to keep the pregnancy, especially since at that point we imagined we'd be together forever. It was romantic to imagine building a permanent life with him. But of course, she had plans. She wanted to go to law school, so she did seek an abortion. She said, I wasn't ready to have a child. I wasn't ready to give up my plans. So this, of course, tells a different story than the person we might imagine in public health who just didn't have access to contraceptives, and that's why she had a pregnancy. This tells a more complex story about love and romanticism, and as well as some of the hopes and dreams we can put into having a baby. And what I'll say here is, especially in my training in public health, one thing that I get frustrated with sometimes is that we treat pregnancy like any other medical outcome. Now, pregnancy is a medical outcome, and many of you deal with this every day. However, let's compare it to a medical outcome like heart disease. Very few people say, I can't wait to someday have heart disease, right? Or very few people say, I really fantasize about having heart disease with this partner, right? So so pregnancy can be so imbued with hope and connection and other things. And so I think I want us to really consider that for our time today. Another example of this comes from Jojo, who was a young man in his 20s, and he was talking about a partner in his recent past, and I had asked, hey, did you ever think about having a baby with that partner? And he said, yes, absolutely. A gorgeous, smart woman like that. Of course I imagine having a baby with her. Like, what are you, crazy? Of course I would do that. And then he was talking about, he'd said that sometimes they use condoms, and sometimes they did not use condoms. And so I was asking him to tell me about that. And he said, well, sometimes she said it was okay not to use condoms because she wasn't at a time in her cycle when she thought she was going to get pregnant. And sometimes she wouldn't say anything. So I wouldn't put one on and we'd have sex anyway, all unspoken. Sometimes I wondered if she wanted me to get pregnant, but get her pregnant in those times, and it turned me on. So again, sort of real complexity around these things. While Jojo sort of describes this more active eroticization of pregnancy risk sort of in the sexual moment, other people talked about it more passively. So some of you may have friends who have said things like this, like, well, we're not trying to have kids, right? That's a more passive kind of approach, right? So it's not that you're actually trying to have kids, that you're maybe not trying to have kids. So Joseph was also talking about a partner that sometimes they use condoms and sometimes they didn't. And he said, if I don't know a girl, I'll definitely use a condom. But if we're really into each other, and then he was reflecting on this one partner, a pregnancy with her wouldn't have been terrible, even though we weren't trying to have kids, right? So you see again this kind of complex. Very few people say like, well, heart disease wouldn't have been terrible, right? And most people just want to avoid heart disease. The last example comes from Lydia. Lydia was one of those folks, I know you all have patients like this. She was extremely afraid of getting pregnant, used 3 different methods of birth control, said something like, I was on everything but roller skates, to avoid getting pregnant. But she had a pregnancy scare, her period was late. It was with the man she had gone on to marry and have children with. She was reflecting back on this pregnancy scare. She remembers being in the bathroom and taking this test, and it was negative. And she cried, and she cried with relief, but also with some sadness. And so she said, after taking this pregnancy test, I was relieved, but also sad. I had gotten excited about the idea of making a baby with him. It was something I wanted to do with him, just not right then, right? So we see these real complexities. So then, when I went to graduate school in public health, we talked a lot about the devices, the services, the programs, the education, right? We talked less about this, right? What actually helps explain what are some of the complex fertility intentions or desires that actually help make behavior like not using contraceptive use make more sense, right? So for the rest of the time, I want us to try to marry these two worlds. So in my remaining time, I want to tell you a little bit about how I define pregnancy ambivalence. I want to share 5 key research findings from my studies and some others, and then end with some clinical implications. All right, so let's start with what is it? And I'm going to highlight 3 things. I'm going to say that it's a concept, an antidote, and a patient-centered outcome. Okay, so let's start with a concept. All right, so conceptually, pregnancy ambivalence is unresolved, unclear, or conflicting feelings about whether someone wants another child. Those feelings can exist in the same person in the same moment, right? Like in the same moment, someone can say, part of me wants to have a kid, part of me doesn't. Those could also exist in the same person over time. So today I might say, my 6-year-old was totally intended. Tomorrow, when he's driving me totally batshit crazy, I might say, oh my gosh, he was so not intended, right? So you can shift also your pregnancy intentions over time. Pregnancy ambivalence can also be anything other than clearly wanting a pregnancy or clearly wanting to avoid a pregnancy. So if we think about that as a spectrum, ambivalence are folks in this middle ground. But I think sometimes in public health and sometimes in medicine, we assume everyone is either on one spectrum or the other, right? Pregnancy ambivalence can also be a psychological factor that helps explain fertility behaviors, right? So as I've tried to point out, contraceptive use is not solely dependent on knowledge and access. So even though those things are requisite factors, someone who feels ambivalent about pregnancy may choose not to use contraceptives even though she has access to them. And it's also a dynamic and constantly shifting state. So there's this new study out of the Guttmacher Institute who interviewed people every 3 months for a couple of years, and pregnancy intention shifted wildly over the course of the data collection. So people are just sort of constantly changing their minds about these things. So it's a concept, but it's also an antidote. And by antidote, I mean it helps improve upon some former measures that we've used for years that may not meet all our needs. So people like myself and many colleagues have criticized these more static, dichotomous models of pregnancy intention. So we, as many of us in our reports and papers and talks with people say, 51% of pregnancies are unintended, right? So that's a statistic that we use a lot, and that can be a very powerful statistic. However, historically, those reports come from women retrospectively reporting on prior pregnancies, even maybe with a baby in their arms, right? You know, they're reflecting back on whether that particular baby was intended. So it's at the time you got pregnant, did you want to become pregnant? And if so, did you want to become, if you didn't, was it later that you wanted to become pregnant or never again? So those pregnancies classified were either intended, wanted right at that time, or unintended, either mistimed or unwanted. And people have criticized these as not necessarily resonating with actual patients, particularly the distinction between unwanted and mistimed. You know, if you'd asked me at 20, do you want to have a kid? I would have said, no way, right? And then later in my life, I might have said, yeah, maybe. Critiques, what's interesting is that the critiques of these conventional models of pregnancy intention now form their own robust body of research. So there's a bigger volume of literature critiquing these models than there is of literature actually kind of empirically validating these models of unintended pregnancy. Yet most of us, including myself, still use unintended pregnancy in the intended way, so in the classic way. So I think we're all struggling with this. Finally, there's some people who really think that pregnancy ambivalence is a more patient-centered outcome than unintended pregnancy. And there's some, I'm not sure I'm in this camp, but there's some people who have said the concept of unintended pregnancy may not be patient-centered, because when you actually talk to patients or actual people, they don't necessarily resonate with the categories that we use as researchers. And particularly mistimed and unwanted may not be salient concepts for actual folks, right? And again, think about someone who wasn't planning to get pregnant, got pregnant, had the child. That pregnancy could, you know, it's very hard for someone who ends up having a child to say, like, this was totally unintended and therefore a terrible thing, right? And so I think pregnancy ambivalence may better capture people's orientations toward pregnancy. So I think it's also can be a patient-centered outcome. All right, so given that I've tried to define it, I want to now share some research findings about it. And there are 5 I want to highlight. And I'm going to give you a summary of the 5, and then I'll go through them, okay? So the 5 are: ambivalence is common. Ambivalence is strongly associated with contraceptive use. It involves multiple domains. It may mean that some people opt out of LARC, and young men's ambivalence matters too. So let's start with the first one, that ambivalence is common. All right, so it depends on how you define it. However, the studies that I and others have conducted, upwards of half of all people at risk for unintended pregnancy may be ambivalent about pregnancy. And when I say at risk for unintended pregnancy, I mean people who say they don't want a child, but who are having penile-vaginal intercourse, okay? So that means if they got pregnant during that penile-vaginal intercourse, they could have an unintended pregnancy. What we're seeing is that this is likely most common among young adults. So these are folks, think about folks in their 20s, say their mid to late 20s, compared to teens. In your 20s, you're more likely to be maybe completed with your schooling, you're more likely to be cohabiting with a partner, you're more likely to be thinking about kids sometime in the near future. And so for young adults in particular, pregnancy ambivalence can be very salient, as opposed to many teenagers who are much more clear, like, no, I really don't want to be pregnant right now, I want to finish school. But many studies have uncovered pregnancy ambivalence among adolescents. So what I'd like to do is show you two statistics about this. One is we've been working with a national survey of family growth. So this is a CDC study. Many of you are familiar with it, nationally representative of 15 to 44-year-old adults in the US. This is how we measure things like birth rates over time in our country. So what we did here, we used 2 questions. We used a question of, would you be upset to discover that you were pregnant? Or would you be pleased, right, to discover you were pregnant? And this is among people who say they don't want to be pregnant, okay? The red bars are women and the yellow bars are men. So what we see, let's focus on this box. So among people who say they don't want to be pregnant, almost half of women and more than half of men say they would still be pleased to discover a pregnancy. So you'd see, again, very different statistics with heart disease, right? Let's look at one other study. We were doing some work with what's called the Fog Zone Survey. This was a survey done by the Guttmacher Institute and the National Campaign to Prevent Teenage and Unplanned Pregnancy, focusing on young adults. And here, the way we define this, so In the unambivalent category, we put people who said they wanted to avoid pregnancy and who would be upset to discover a pregnancy, right? So there's an alignment with their intentions and their feelings. And then people in the ambivalent category are people who said they wanted to avoid pregnancy, but they would be happy. And similar patterns. So about 46% of women and 53% of men were qualified as ambivalent in this study. So all this to say, at least based on these pretty robust data sources, very, very common among the patients that we see, that you all see every day. So ambivalence is common. It's also a strong correlate of contraceptive use. So this makes total sense, right? So we spend a lot of time trying to explain and improve contraceptive seeking behavior, right? We try to improve education, we try to improve access and services, we try to do really good counseling to minimize side effects and encourage continuation. What we hadn't paid a lot of attention to is, gosh, even clients coming to family planning clinics may actually feel kind of ambivalent about pregnancy. Maybe we should find out more about that. So several studies have demonstrated much lower odds of effective contraceptive use among those defined as ambivalent. And in this report by Jim Jackard and the National Campaign that came out in 2009, they identified 9 or 10 very key things that we need to do better to help address unintended pregnancy among young adults, and pregnancy ambivalence was one of those identified. There's several ways that ambivalence can affect contraceptive use. In the consistency of use, like those quotes of Jojo and I'm forgetting the other gentleman's name who talked about using condoms some of the time and not others. It can also affect the type of method used. And this comes out in the LARC data that I'll show you later. If you're really clear you want to avoid pregnancy, you're more likely to find your way into using an IUD or an implant. If you're less clear, you might find your way into a pill or condom use or withdrawal. And also, ambivalence leads to gaps in use or non-use. And I want to show you some findings from this last point in particular. So this was another nationally representative study of adult women at risk of unintended pregnancy. And so what we have here, these are patterns of contraceptive use. So this 38% of people use the same contraceptive method all year. This quarter switched almost always from a more effective method to a less effective method. And then the 15% bars are either gaps in use and they weren't at risk because they weren't sexually active, or gaps in use when they were at risk, and then non-use. So we're very interested in helping explain what's going on with this group here, given that this group contributes a larger proportion to the unintended pregnancy burden than any other group. And what the investigators found is that pregnancy ambivalence was significantly associated with those groups. And in fact, it was more strongly associated than any other demographic factors, such as race, ethnicity, education, poverty level. So the things that we think are really associated with contraceptive use are very important, but so too is this, is one's orientation toward pregnancy. Okay, what I'd like to do now is my third research finding I want to share with you, is that pregnancy ambivalence involves multiple domains. And you're going to have to just bear with me for a minute as this stuff can be really, I think, dry to folks who aren't as mired in behavioral science and psychometrics as I am. But what do we spend a lot of time trying to think about is, when we talk about ambivalence, what are we actually talking about? Is it a difference between what people say their intentions are and their feelings? Is it fatalism? What is it? So we've done a lot of work on this, both in our qualitative studies and our quantitative studies. And here, I'm just going to highlight a few of the domains. So one domain is your strength of motivation to avoid pregnancy. How strongly do you actually want to avoid a pregnancy? That seems to be important. Also, how happy you might be upon learning of a pregnancy. That certainly is an aspect of this. So even if you're not trying to get pregnant, could be that you or your partner would feel really happy. This seems to be huge, and I'll talk about this in a minute. Indifference, right? I don't know how many of you have patients who articulate this, but in several of our surveys and studies, we have people who say, when asked, how do you feel about getting pregnant? They say, I don't know, or I don't care, right? And it's in that one key question tool, there's a, yes, I want to be pregnant, no, I want to be pregnant, I don't know. And that might fall into this indifference category as well. This is a domain. Pregnancy would be okay. I wouldn't mind, right? So those aren't people who are saying they would be happy necessarily, but nor are they saying that they're avoiding it at all costs. Fatalism. We see this in a small but very important minority of people who say, it doesn't matter whether I use contraception or not. when it's my time to get pregnant, it will just happen, right? Now, you can see that there probably be some religious influence on that. Some communities may be more likely to espouse this, but across all sociodemographic groups, we see a small but significant minority of people agree with this. Orientation towards parenthood. Like, I think that being a mother is really important to me. I think I'd be a good mother, or I think I'd be a good father. Those things can influence pregnancy ambivalence. Perceived readiness for pregnancy can influence this. And then this is really key. A pregnancy with this partner would be positive, right? So several investigators have found that women's pregnancy intentions can shift greatly depending on what they perceive their partner wants in terms of pregnancy intentions, right? And then finally, this sort of social norms and attitudes. If in your community having unintended pregnancies is more common, if you have few opportunities for schooling and education, then again, one might be more ambivalent about pregnancy as opposed to trying to avoid it at all costs. So those are some of the domains. What's tricky is that there are few consistent measures used. So the domains I just highlighted are domains that we've seen in a variety of studies, sometimes in the same study. And one of the things I've been arguing is let's come up with some sort of better set of standardized measures that we could do as a group. I'll just say that some of the explorations I've been doing lately have been trying to explore which domains actually matter the most for contraceptive use. And so I've been working with this data set, looking at several of those domains to see what tends to make the most difference in predicting non-use, contraceptive non-use in the last month. And what we find is that it's indifference that matters the most. And so I'm not going to go through this slide in great detail, but what this shows is these are results from a multivariate regression. So basically, what we're trying to do here is predict how much do four different measures of pregnancy ambivalence help predict contraceptive non-use. And so what we see is the definition we used that captured this indifference, people who say, I don't know or I don't care what happens, that was the most robust measure to sort of predict non-use. So we're doing some more exploring to see how could we better identify these folks, what might we do about them. All right, the fourth research finding I want to share is that pregnancy ambivalence may mean that some people opt out of LARC methods. And I want to share some findings from a qualitative study that Eliza Bennett and I did here in Dane County, where we did interviews and focus groups with young adult women. So I think one of the reasons I love qualitative research is that it helps give words to things that if you just considered the behavior doesn't make sense. But then when you hear people explain them, it's like, oh, I understand now why you are not getting an IUD, right? So there were three themes that came up that I want to share with you. The first thing that came up in the study is that for better and sometimes for worse, people saw LARC methods as ruling out the possibility of accidental pregnancies. Now, from our perspective, this is really good news, right? Like you want a contraceptive method to rule out accidental pregnancies. However, there are some people, because of pregnancy ambivalence, who don't want that in a contraceptive method. The second theme is that age and life stage and relationship stage all influence this, so that I'll talk about what that means. And the third theme was that LARC could feel too permanent to people who thought they might want kids in the next few years. So even though people realized that LARC wasn't permanent, they still perceived that it could be. And they were also worried that it might potentially make it more difficult to become pregnant later. So we just want to highlight some quotes to illustrate these themes. So this is a theme that LARC methods could rule out the possibility of accidental pregnancies. So this is Kayla. Kayla had a child, was happily partnered, and she was saying how she might want a second child sometime in the near future, but she didn't want to plan it. She didn't want to go do it. She didn't want to deliberately have a child. She said, I guess one of the reasons I haven't gotten an IUD yet is like, I don't know, having one kid already and being in a long-term committed relationship, an IUD takes the element of surprise out of when we would have our next kid, which I kind of want. I'm in that weird position. I just don't want to put too much thought and planning into when I have my next kid. So Elizabeth was somebody who was a very satisfied LARC user, but she was talking about some social norms in her friendship groups that help explain this. So she said, like, if you're a couple, IUDs and implants really take away the element of surprise of having babies, which some people want and some people really, really don't want. Like you can accidentally forget your pill and get pregnant, but it's not like your IUDs is going to pop out and take a jog around the block, right? And so we did have a number of people talk about this, that they were using contraceptive methods like pills, but because they had some pregnancy ambivalence, they weren't always taking their pills, or they sometimes would skip a month. So even among contraceptive users, right, we saw this complexity. Okay, then the second theme was that age and life stage and relationship stage all influence pregnancy intentions and people's willingness. I'll say that I think we throw teenagers under the bus a lot. Teenagers use contraceptives better than anybody, right? It's truly, right? When you look at both contraceptive use rates and condom rates, teenagers are better than anybody. The reason that we focus so much on them is that the costs of an unattended pregnancy are really high when you're a teenager, right? So the proportion of pregnancies among teens that happen that are classified as that are unattended is high, but again, they tend to use contraceptives pretty well. So younger people tended to actually say, yes, I would be a good candidate for LARC. It was people in different life stages who said, no, I don't know if that's the best method for me. So Crystal was a university student, so she's one of these young, focused, unattended pregnancy would be a bad thing for me. She said, well, I'm like in my early 20s and still in college, so I don't want to have kids for a while. So the IUD feels like a lot more of a viable option for me. But if I were like 7-10 years older, I'd be a lot more hesitant, even if I didn't want to get a kid right then. So she was sort of forecasting, okay, in the future, I might want kids at that stage. I don't know if I would choose that method, even if I wasn't sure. Beth was a little bit of a later life stage. She was in her late 20s. She said, if I were to get pregnant with my long-term partner right now, I probably feel extremely confused, given that I'm in a committed relationship but not ready for children. So she wasn't planning to have kids. If I were to get pregnant in a less intense relationship, I would get an abortion. But if you're with multiple partners, the IUD makes it hands down easy to know there's no chance of anything happening with anyone, anywhere, anytime. So this was really clear. People who had multiple partners or people who were in early stage relationships saw the IUD or implant as really good options. People who were in loving relationships and who had partners with whom they had imagined having a baby someday were opting out of these methods. And then this is the final theme, that LARC could feel too permanent to women within striking distance of wanting children. And again, nobody in our study said LARC is permanent, right? Everyone understood that it's a reversible method, but there was still this perception that it was more permanent than other methods. So here's Jazz, who's a community focus group participant. I need to remind myself about Jazz, hold on. Okay, this was someone in her mid-20s, and she said, I may want kids sometime in the next year or 2 or 3, so I feel like the implant's a little too permanent me, like at this stage of my life. And finally here, Janelle was a community interview. She said, there's this perception of permanence with the IUD. A couple of my friends were like, oh, that seems very drastic. So Janelle had an IUD and was happy with it. She said, if you were saying, well, we don't want kids right now, but we might in a couple of years, so I want to get on the IUD, your partner might say, why don't you just go on the pill? That's easier and it's cheaper and faster and you can stop it at any point instead of having to go to a doctor and argue with them about whether or not they're going to take it out. I'll just leave it there. So what we found in this study is that young women describe pregnancy intentions as very nuanced, right? So nobody in our study said, here's how I think of pregnancy intention. It's unintended here, and then it's mistimed here, and then it's unwanted here, right? No one used the categories that we use in public health. They talked about this nuanced spectrum, and they perceived the best IUD and implant candidates as those strongly motivated against pregnancy, which totally makes sense. People who were less motivated and or less clear might deliberately opt out of IUDs and implants. And I think I'm sharing this just because I want us to be sensitive to the fact that not every patient who doesn't select a LARC is a failure, right? In this case, choosing a method like a pill might really meet their needs better than an IUD or implant. All right, the fifth and final research finding I want to share with you before I talk about clinical implications is that young men's ambivalence matters too, right? So it matters actually just as much. So what we found in our research is that young men may be more likely to express ambivalent attitudes than young women. I'm going to show that slide I showed earlier in a moment, where I don't know if you remember, but the proportion of men classified as ambivalent in 2 of our studies was greater than the proportion of women. We wonder why this is. I think some of it is that since childbearing is disproportionately done by women, young women may be clearer to show how their lives would be limited by a baby, right? So I think it might be potentially that if a young woman is considering pregnancy, she might sense, okay, I don't know if I'm ready to raise this kid on my own or with a partner, so I'm going to be clear, but men might be a little bit more ambivalent. I'll say that I made this statement in a paper recently, since child rearing is disproportionately done by women, and the reviewer asked me to come up with multiple citations for it, and I was like, wait, are you serious? You know, like it was one of those moments where I was a little irritated with my reviewer. I felt like that was sort of an established fact in our culture, but perhaps not. So let me show you a few, although not to say that men aren't incredibly involved in child rearing, and my partner has my child right now, so I don't mean to be saying men aren't incredible fathers. And so what we also found is that men's ambivalence may be more strongly connected to contraceptive use than women's, and this was something that was surprising to us. So remember this slide I showed you earlier. So this is from the fog zone study. So this is showing the proportion of women who in our study classified as ambivalent versus the proportion of men. So not a huge difference, but nonetheless, men are slightly more likely. But then what we looked at is among those groups of ambivalent people, what are the contraceptive methods that they use, right? So are these people less likely to use contraceptives effectively, or are these people less likely? And what we found is that the relationship was in the expected direction with both women and men, but it was only significant for men. So that pregnancy ambivalence was significantly associated with young men's use of male-controlled methods in the last month, so condoms and withdrawal. So what we found is that the men who are clear they don't want to be pregnant were much more likely to use condoms and withdrawal than the men who were less clear they wanted to be pregnant. But what we found that with young women's use of female-controlled methods, the relationship was in the expected direction, but it wasn't as significant. So what we think is that young men really can be motivated to prevent pregnancy and want to play their part through condoms and withdrawal. So I think we sometimes, again, you know, as we do with teenagers, I think we sometimes throw young men under the bus that they don't want to actually participate in contraceptives. So many of them do. And so I think that young men's intentions to avoid pregnancy can be influential on contraceptive use, and men's hopes for pregnancy can also lead to less effective contraceptive use. Okay, so finally, I just want to end with some clinical and practical implications. I'll say that it's much easier to just talk about the complexity of all these things than to say, and here's exactly what we should do about it, right? So I don't have perfect tools, but here are just a few ideas. Okay, so at the very least, I hope that that being more familiar with this literature can help us bust some assumptions about maybe the patients that y'all see. So one is that I've tried to establish pregnancy ambivalence is extremely common, and not all patients want to avoid pregnancy strongly all the time, or not all patients want to be pregnant strongly all the time. So and this is true even among those seeking contraceptive services, and I think this is what's been shocking to us. So it's not just that ambivalence is common in a general population sample, it's that ambivalence is common in clinical samples of family planning patients. Ambivalence shapes contraceptive practices, but involves multiple domains and is dynamic over time. So the person who says she's ambivalent today might not be next week, right? So it's really tricky to know exactly where to meet a patient like that. LARC opt-out or contraceptive non-use may not always mean lack of knowledge or lack of access. So even though we have a really important job to disabuse people of misperceptions about LARC, like, hey, it's not affected with future infertility, there are all these really great things associated with LARC, we also still need to accept that someone may still choose not to use it, particularly if she's ambivalent about pregnancy. And young women's intentions aren't the only ones to influence whether and how contraceptives are used. So, you know, I think I've been really spending more time recently thinking about what can we do about this. And I mentioned this report put out by the national campaign a few years ago called Unlocking the Contraception Conundrum, Reducing Unplanned Pregnancies in Emerging Adulthood. And they really highlighted the importance of paying more attention to this notion of ambivalence. So I think at a minimum, we could at least recognize the link between these various things, pregnancy intention, ambivalence, contraceptive use, and recognize that this is untrivial, right? That young adults and in particular can have very, very high proportions of ambivalence. And what these folks have argued is to put resources and efforts into helping emerging adults sort of think through the implications of having a child, right? So this is so difficult in your clinical work, given that you have so much to do and talk about, but I hope it's something that we can continue to think about in contraceptive care. So for example, One thing that I've talked to a number of groups recently, some adolescent health groups, who are more interested in adding questions on intentions and ambivalence to their intake forms or their counseling protocols. And some of the questions they've used, this is true even among people seeking contraceptive services. Some of the questions they've used have been things like, how important is it to you to avoid pregnancy right now? And they've included these indifferent options, right? Not sure or I don't care, since those folks might be really critical. How happy would you feel if you found out that you were pregnant or your partner was pregnant? How do you think your partner would feel? And these questions can at least provide a starting point. Again, you all are so burdened in a clinical encounter, so I don't mean to say, just add these questions to all the other ones you're asking. But I think that we're again, as we sort of try to shift contraceptive counseling, maybe more to support staff, these could be some of the other sorts of questions that we think about integrating. The goal, of course, is not to convince patients that they should feel a certain way, although this must be very difficult at times, but to help them consider and talk through options. And I'll say that some of you may be more trained in this than I am, but I've been really impressed with what I've heard and read about motivational interviewing. So what I understand about motivational interviewing is that it honors the part of a person that both wants to do something and doesn't want to do something, right? So let's think about someone who wants to stop smoking. Motivational interviewing might get that person to talk at length about the part of them that wants to stop smoking, what their life would look like if they stopped smoking, but also the part of them that does, right? And what they'd be giving up, right? To actually honor that part of the person instead of just dismissing it or suppressing it. And so there could be, and there was a Planned Parenthood group in Delaware who was doing a little bit more of this. What part of you would like to have a baby? What part of you would not like to have a baby? And they had found incredible traction with this among their adolescent patients. Because adolescents, we almost always either assume or hope don't want a baby, right? And in fact, by asking their adolescent patients, tell me about the part of you that might want to have a baby, they could sort of unsuppress that and get folks to talk about it, and then talk a little bit long range. What would your life look like 5 years from now if you had a baby? What might it look like if you didn't? And so helping clients maybe talk through these options so that they could maybe be a bit more connecting with their contraceptive behavior instead of sort of letting it just happen. Helping young people recognize potentially the connection between these things could be helpful. So I've worked with some groups who talk to patients along these lines. Do you know that some couples are less likely to use contraception on days that they feel particularly connected or in love? Does that happen to you? Can we talk about that? Maybe if that happens to you, maybe that we should talk about something that you don't need to worry about using on a day-to-day basis. But of course, we've got a lot more work to do on which domains may be the most important and how to ask about them. And so there's going to be this big summit of people who get together at the Buffett Foundation in the next 6 months or so to talk about this. And I hope that we solve all the world problems at that summit. So just in terms of proceeding with caution, I think this is true for me. I don't know if this is true for you. People have difficulty clarifying their pregnancy and parenting desires, right? The fantasy is that everyone we work with is either super clear, they don't want to have a kid at this moment, or they're super clear that they do. But in fact, many of us somewhere are in between. And I wonder if we can or should encourage all people to exactly how and when they'll have children. I think this is an underlying goal of public health. It's unstated, but I think the goal is, well, every pregnancy should be planned to a T. I don't know if that's a reasonable goal. You all may feel differently, and I'd love to hear your thoughts, but I just want us to make sure we're not drawing from that unstated assumption without examining it. And some people have engaged in values clarification around this, particularly if they work with adolescent clients or clients who've had repeat unintended pregnancies. And it's so frustrating when they come in and they have another one. It's like, oh my gosh. So, but I think sometimes people have really had luck with trying to do some values clarification around this. Like, what is this person? How are these person's choices different than my own? And I think trying to really trust patients around making good decisions around pregnancy can be really, really hard, and something that I don't have to deal with from day to day, but something that can be so important. Okay, I will. My last slide here. I also just, I always say this to myself. Okay, we can't solve everything. We can't fix all these problems right away. We're still developing better measures and scales to be used in clinical settings. We hope to have tools that we can develop for you all. And it's still very difficult to reach young men in many of our programs. So even though I'd love to see young men more involved in this work, I understand why they're not. We're still in the process changing and evaluate how we evaluate success. And I've talked to a number of groups lately where I remember this physician in New York saying, "I feel like such a failure if my postpartum patient doesn't leave with an IUD, right? Like I feel a sort of sense of failure if my patients aren't selecting LARC, and that's so not doing a favor to the clinician or the patient in that environment. So I think we're trying to shift a metric of success to not necessarily the numbers of IUDs placed or the most effective methods used, but the number of satisfied clients, who feel like they have the agency and knowledge to prevent pregnancies they wish, right? So even though we might want or hope our clients to prevent more pregnancies than they're preventing, if it's working for them, then that's a success. And we need people to feel supported and respected in these endeavors. Thank you all for your time. I really appreciate it, and I look forward to your questions. Thanks.
Hello. Hi. What a great presentation. Thank you so much for sharing your research and the work around this. It's open to questions.
Thanks, Jenny. That was great. I'm really interested as to whether or not there's any qualitative research that looks at the difference between asking the question, are you interested in pregnancy at this time or no pregnancy at this time, as compared to the question of, are you ready to begin parenting at this time?
It's a really interesting question. That's a really interesting question. Can you all hear me? I don't know if the mic is on. And I haven't seen research comparing that. But could you talk that out? What do you think would be the differences there?
I think we make assumptions when we ask about pregnancy, that people are thinking what the potential implications are.
Right.
So if you're pregnant now there's choices. Are you going to keep the pregnancy? Are you interested in abortion or not? Are you going to adopt, or are you going to parent? And the at least in our culture, the oftentimes value assumption that goes along with the question, are you interested in pregnancy at this time, is we're sort of asking that bigger, what's your reproductive life plan?
Right.
In that, what's your parenting plan?
Yeah.
Do you have one? And I can see where the answers might be very different, male versus female, but I don't know. And I would say that would be my assumption bias.
No, it's a great question, and it's getting my wheels turning. I mean, I think that I don't know if this was in the quote for the very first quote I opened with, Lydia, who was the law student. She said she loved the idea of being pregnant, but then when it came to thinking about, oh shit, do I really want to be a parent? No, I don't want a kid I can't deal with, right? But the idea of being pregnant with this partner is really appealing, right? And so I think reproductive life planning has really tried to get, it's not totally like motivational interviewing, but it's in the spirit of having people talk out what ideally do you want to happen in your life. And so I think that for this is anecdotal and not empirically based, but my sense is that would lead to greater insights than, do you want to be pregnant right now with your partner? So thanks for the point, Mary.
Thank you for the presentation. I have a comment and followed by two questions. Recently, I read an article on macroeconomics from University of Chicago. A lady published a study. Actually, she is an economist who looked at the fertility and marriage rate in the communities that are subjected to a boom in economy, because they're trying to single out what is the most important factor that boosts the fertility. And obviously, she was funded by a conservative group, so they wanted to look at the marriage rate. What she found that communities and societies that are subjected to a boom in economics, their marriage rate stays flat and maybe even dropped, but their fertility increased.
Increased, interesting.
So that tells me, listening to your talk, that tells me maybe that state of ambivalence is really linked to a state of finance and the economy and boom. So I wonder, there's two questions. I wonder if your studies or studies you have done took into that economy and the income, whether it actually, when it fluctuates, it increases or decreases the ambivalence. And so the second question is, if that is true, will the state of ambivalence be more strict or less ambivalence when you are poor? And so those are the people who we have to target to help with a long-term contraception, because when you are economically stressed, maybe your state of ambivalence will be a little bit lower, much lower than when you are economically relaxed. And then those are people who we might have to help. So those are my thoughts. Thanks.
No, I really appreciate that, and I haven't, I'm not familiar with that study. I think the underlying sentiment is I agree with it so fully that how one feels toward pregnancy is very much imbued in a larger context of your resources, your opportunities, your community, and other things. There have been some studies in low-income communities. There's incredible, several of you may have read the book Promises I Can Keep. It was a 3-year ethnography done in a poor community in Philadelphia. And what she was saying is that economic scarcity actually led to greater unintended pregnancy and lower marriage rates because there were so few opportunities for schooling and really great educational opportunities. But that was one study, not a comparative. So, but I think it's so important. I will say that one recent presentation from a sociologist on this issue found that when we look across all socioeconomic levels, that ambivalence was actually a little more common among the upper middle class. And I think we could all imagine, just anecdotally, some of our friends or ourselves perhaps is like, gosh, do I have a baby during residency? Do I have a baby after? Like, when do I actually do this? Whereas if you have none of those opportunities, it might be a little clear, like, of course I'm going to have a baby earlier, but this notion of how resources are connected to the situations under which how we want to have kids, it makes sense. And the last thing I'll say is, one thing that I have really tried to fight against, I think, especially sometimes in public health, we can say unintended pregnancy causes poverty. But actually, I think it's poverty causes unintended pregnancy. So if we really want to reduce unintended pregnancy, we need contraceptive services, but we need to reduce poverty. And so I think, to me, that would also be sort of a takeaway maybe from this study. But thank you for that. Hi, Katie.
Great presentation. Thank you for coming to talk to us. One thing that I found interesting of the data that you presented is sort of the perception by patients that, they know LARC isn't permanent, but they kind of view it as being kind of too long-term. And I think that it may be partly related to what that one gentleman said about how, if the pregnancy plan is for 2 or 3 years, not necessarily 5, 10, or, anything like that, that the idea that she would have to go in and argue with the doctor to get the LARC out, or whether there's anything sort of on the provider side where, as they're going through the counseling, if the woman's plan is for 2 or 3 years, do they think that it's not worthwhile, to put in an expensive IUD, even though for the woman it's really only $15 copay, whereas pills are monthly, you know what I mean? So, right.
It's such a great point, and one that you all must struggle with on a daily basis, right? Because I can imagine, especially with Medicaid patients for whom they can't get another LARC device for 3 years. It's like, oh my gosh, this was expensive. Like, can you just leave it in a little longer? So I think, and there's some great qualitative work on this by Jennifer Amico and colleagues showing pressures on providers to not remove devices when the patient requests it, right? So I think when I shared results with Eliza from this study at a Grand Rounds a couple of years ago, there was this great patient example of a woman who'd gotten an implant. She'd had a lot of difficulty with it, but she'd had this provider say to her, no matter what happens, I've got your back. So if you run into trouble with this, I will take it out, right? And so because her provider, in my perception, because her provider had said that, she said, I'm having all these issues, but I'm going to stick with it. And she did, and then the side effects evened out. So I think it was getting that reassurance from a provider, like, I think this will work for you, but if it doesn't, I will help you remove it. Like, to me, that might be a really powerful message to send to clients, even though I think providers get so much pressure from payers and as well as culturally to like have the patient leave it in as long as they can, or have them try to get through that period of side effects. Does that answer your question, Katie? I don't know if you had any other thoughts on that.
Why patients aren't getting them in the first place, whether they perceive that there will be pushback,
right. Or yeah, and is Carly Carly here, or did Carly move? Carly is very sad for us. Very excited for Carly. So Carly worked with these data, and she focused on this issue of autonomy, patient autonomy. Some patients said, I perceive that a LARC would lower my autonomy because I would be dependent on a provider to take it out. And so that it's a non-starter for me. Some patients felt like, no, this IUD will give me a ton of autonomy because I don't have to do anything and I'll be really protected against pregnancy. So not all patients are going to be the same. And that just, so yes, that she definitely found evidence of that. Yeah.
What do you think the relative importance is of patients not accepting the LARC between ambivalence versus access or whatever?
Thank you for that question. It's such an important point. To me, access is the biggest issue that we need to tackle, both access and misperceptions, right? So this was a few years ago, and I think LARC is changing every year, but we still had patients who felt for sure that you shouldn't get a LARC unless you'd already had children, who felt like LARC would compromise your future fertility. So those misperceptions, as well as access and cost issues and reducing barriers to cost and removal, those seem really critical. I think so for me, the point I'm trying to make to you all is you still may have some patients who opt out of this, and that isn't a failure. Like, you haven't failed if that's the case. Does that make sense? That's a great point, right? Absolutely requisite, critical is providing contraceptive services, access, and knowledge, right? So those things are mission critical for all of us, and that's what gets me out of bed in the morning. But even within that, there may be some people who choose not to access those services, and we need to not see those people as somehow failing. Does that help? Yeah. Thanks. Yeah. Okay. Right. And the navigator in this case is a person, not like an app. Okay. Yeah. No, thank you. It's a great insight. I think that so some people may have heard of Upstream USA. They're this sort of consulting organization that they come into clinics and healthcare systems and help them sort of stream their contraceptive care, including their LARC provision. And they have really emphasized a model of task shifting contraceptive counseling out of providers, not because they are not incredibly capable, but because you're so pressured for time, to to social workers, to navigator type folks. And so I think we may see that move more and more. Christine Dellendorf and other colleagues at UC San Francisco are also developing some really great patient aids to be used in waiting rooms. It's different than dealing with a person, but these patient aids can really help an individual patient weigh in with, this is really important to me when I choose a contraceptive method, and this is less important to me. And then the counselor or the provider has that information and can make specific recommendations. So as opposed to what I think sometimes happens in contraceptive care, we don't know about those personal preferences, so we automatically lead with like particular set of devices. So I think that we're moving that way as well, but it's a really good model. I'll have to look more into it. Hey, Nicholas. Yeah. 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 Right. Right. Right, 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 right. Yeah, right. No, it's, yeah, please. Right. It's a great point, and not one I'm perfectly equipped to answer, but I think you're really getting onto something that matters a lot. And someone told me once that we dramatically overestimate what we can get done in a year, but we dramatically underestimate what we can get done in 5. So like, we just this sort of concept of what's a long time, what's a little time, when what's far in the future. So I think there's something to that, and I don't know how much, say, the reproductive life planning gets at that issue, like in 12 months or in 5 years, but I think, again, maybe some reassurances over, 3 years isn't that long, but if you want it out before then, I can help you take it out before then, right? I mean, and so I think, again, I'm not a clinician, but if I were, I might emphasize that, like, you could, we expect that you might like this and use it for longer than a year, but even if you don't, we can help you. I mean, that, I don't know if that would help, but it's a great question. Right. Yeah. Right. That's really interesting. And we haven't looked into that. I don't know. I mean, I'm thinking about my own self and moments when I felt ambivalent. I don't, if someone had pointed that out to me, it might become more a little clear. But I don't think folks look at themselves in the mirror and say, today, do I feel ambivalent about pregnancy? Like, I think, it's just part of one of many things that they're thinking about or not. And so, no, I doubt that there's actually a cognitive awareness of it. And so motivational interview brings that cognitive awareness more to the forefront, right? It's a great, great insight. But did you? Yeah. Yeah, right. You were the what ones? The right, right, right. Yes, yeah. Right, right. Yeah. Right. Yes. No, it's a good point. Yeah. Right. We expect everyone. No, it's a really great point, and I also think this notion of, like, what do people actually want? We should remember that contraception is sort of the least bad alternative, and what I mean by that is, few people say, I can't wait to have sex with contraception, right? Like, I can't wait to use the pill. Like, I can't wait to use a condom when I, like, get it on this weekend, right? People use contraception because they have to, not because they want to. And so I think sometimes from our perspective, we're, as rational actors, as people researchers, is like, why don't you just use a method? It's so easy. It's not a big deal, but it's a least bad alternative, right? And so I think we also really need to recognize, and this is where the new patient-centered research is so exciting, that the method, like what one person wants, will differ from what another person wants, and that's why it's so great that we have a wider array, 3 different IUD options and an array of hormonal methods and these things. But it's so complex. I wish I could snap my fingers and have everyone be just like me, right? But that's not going to happen. Yeah. No, thank you. So for folks who couldn't hear, it's like how much role does knowledge play, because it actually really is critical. So what we saw in the choice project in St. Louis is that when when access issues and knowledge issues were reduced, people really use these methods at much, much higher rates. And so it's critical. And I think you all see this every day. Misperceptions about methods are wild, right? And so people can say, oh, my friend lost her, hair on this method, or my friend gained 20 pounds or 40 pounds on Depo. And so I think that dealing with misperceptions is really, really important. And so, I think to your colleague's point, that I'm not at all saying that knowledge and access aren't really important and that we need to absolutely be working on those and reducing. I would love to see the Choice Project or the Collar Project available everywhere, just complete reduction of barriers and upfront, better misperception management. So those are the most important thing. But there may still be. There was a great study of a colleague of mine interviewed about the 100 people who would say published articles on LARC in the last year or whatever. This was several years ago, and said, if all barriers were reduced, how many people do you think would choose to use LARC, right? And nobody said 100%, right? It was somewhere between 30 and 50 or so, or like 10 and 50. So I think we just need to, knowledge and access are really, really important, but even with those things, not everyone will choose those methods, and that needs to be okay. Does that answer your question? Yep. Absolutely. Yeah, it's a good point. Yeah. Right. Yeah. So clarifying misperceptions and making sure patients are really well aware of how these methods work and how they're not going to cause problems. That's really, really, really critical. So thanks for that. I think we're over time. Thank you all. I really appreciate your time today.